Hey, so I have Dr. Brett Scher here with me this morning, and he's actually a cardiologist that is based here in San Diego, and is one of the docs that I'm starting to get access to, I think, who's starting to get the idea, or does totally get the idea about LCHF and the therapeutic benefits of that for many of the chronic diseases, including cardiovascular disease. And he has a really cool podcast and things like that. So he's really getting in on this whole movement. So welcome, Brett. Thank you very much for your time.
Yeah, my pleasure, Doug. Thanks for having me.
Yeah, pleasure. And maybe we could just start with how you stumbled upon this and how you got involved in this whole concept in the first place.
Yeah, it seems like a simple question, but it's really not that simple of an answer. It takes sort of a long circuitous path, which is, I think my path sort of highlights how it's challenging to change modes within medicine. Because when you go back to how we're trained in medical school and in residency, there's all this brand new information to us. And we're so excited to learn it and soak it up like sponges and get in there and help people. And we look up to our teachers and our attending physicians as in awe, because they're these role models who are doing what we want to do. We want to become them. So we become little sponges, and we want to learn everything and memorize everything that has been set out by those people who have been doing this work and clearly taking care of people. And that's what we want to learn. So med school residency, it's all about just soaking up as much as you can get. Then I went into my cardiology fellowship, which was a preventative cardiology fellowship with Dr. Guarneri here at Scripps Clinic. And that was sort of my first taste to a little variation in what I've been taught, because it wasn't quite as focused on fixing the problems once they arise, which medicine can be pretty good at, putting Band-Aids on problems when they arise. Instead, it was focusing on, let's see what we can do to prevent this in the first place. And that mindset certainly sat better with me. And the way the program was set up, it was a whole lifestyle management program. So we got people to quit smoking and start exercising and join communities, and of course focused on their nutrition. But back then, in the, I guess that was late 90s, it was still a low-fat, predominantly vegetarian type nutrition. And I learned a couple things right away. One is the patients didn't enjoy it so much. They were sticking to it because it was part of the program, but boy, did I hear them complain about how they missed so many different types of foods, and they were sick of more tofu and tofurkey and that kind of stuff. The second thing that I noticed was, personally, I tried to eat the same way, because we had our own little kitchen there, and where they made the food, and so I would try and eat that same way, and it didn't sit well with me either. But then more importantly was, I expected to see such a dramatic improvement. And don't get me wrong, there was definitely an improvement, but you're sort of idealistic, and you're going to save the world, and you're going to prevent heart disease, and you're going to kind of just turn off the faucet of the heart disease drip going into the hospital. And it definitely did not turn off the faucet, maybe turned it off just a little bit. But it started to bring up into my mind, well, what's really working here? Because when you look at like the Dean Ornish studies, right? The Dean Ornish study is the one that's sort of promoted as showing vegetarian diets are the best diet. But it really, they got them to quit smoking, start exercising, join communities, manage their stress. I mean, you could feed someone cat food and they're going to get better if you get them to do all those things. And so as I started to look at the research and started to write some book chapters with Dr. Guarneri, it made me start to think, well, the evidence isn't nearly as good as people say it is. Okay, but still, I wasn't able to sort of break ranks, because that's the way you've been taught, that's the way you've been trained, that's what the experts do. But the questions were there in my mind. Then I went out into regular practice, and oh boy, did the world sort of change then. Then it's very exciting and liberating. You're out on your own, and you're really out there to try and help people. But without those same resources, boy, did I see lifestyle management just not resonate with people. People weren't getting it. People weren't improving. And I sort of blame the patient, I hate to say. They're just not trying hard enough. They don't get this vegetarian low-fat diet. They just can't stick with it. And then over time, eventually, you start to realize that, well, maybe there's a problem with what the information that we're actually presenting. And all this sort of came together at the timing when Gary Taubes started publishing books, and then later, a few years ago, Nina Teicholz. And once you start to see a re-examination of all this information, you can't help but question it and say, now it's starting to make sense. All those times in the past where I saw sort of this lifestyle change not resonate with patients not get better, as you see the incidence of diabetes going up, you realize maybe the message is flawed. And once you hear somebody in an intelligent way present how flawed the research is, it sort of resonated with what I had thought in the past with the Ornish studies and the lifestyle modification studies, that there's too many confounding variables to say what's right and what's wrong. Put that also together with, I started working with a good friend of mine, Dustin Schaefer, who's very involved in the low carb community and has been for decades, actually. He's been doing ketosis, nutritional ketosis for over a decade now. And all of it came together, and I said, okay, now I think we're onto something, because once I started experimenting with that with patients, you start to see that there's better compliance and they start to feel better, and being healthy isn't such a torture, and you see their diabetes measures improve. There was still little concern about the cholesterol component, but that's evolved over time too, and I'm sure we'll get into that. But that now I've really come to be confident that that's less of an issue with metabolic health. But that's sort of the general progression, and I know that was maybe a painstakingly detailed explanation, but I think it's important to see from a physician's standpoint how the tide changes pretty slowly, because we're ingrained with what we're taught, and it's everywhere from our standpoint. The guideline-based therapy, what the AHA dietary guidelines are, what is standard of care medical practice, and there's a little bit of a fear and trepidation to go outside of that standard of care, and that's why it took me quite a while to kind of come to this point. But once you get the personal experience and the experience with your patients, and you have the open mind to question what's been done before and the research, and to really analyze it on its strengths and tremendous weaknesses, then all of a sudden a whole new world opens up. So that's been my sort of progression to where I've come.
Yeah, I mean, you mentioned you struggle in the practice, because I know you were telling me before this that you have, 8 other cardiologists in your practice?
Right.
And if I'm correct in what I'm remembering, you're saying that you're the only one that really advocates this LCHF concept. So the other 8 still don't.
Correct.
So how do you manage that? And, I mean, it must be difficult to be in a practice where you're the only one.
Yeah, it is interesting. A lot of the times we're managing our own individual patients. So I can manage my patients the way I want. When we come together and we talk about issues, or we're kind of sharing patients, that's when it can become a little uncomfortable, because we have very different philosophies. And you can break it down according to the doctor. Some doctors just aren't all that interested in lifestyle. It's a sort of a primary care issue. They're interested in putting in stents and putting in new heart valves and doing these amazing things that cardiology can do. We can put in new heart valves without cracking a chest open anymore. I mean, that's pretty incredible that they can do that. So, some people are more focused on that. Some people are more focused on the pacemakers and the defibrillators. And then there's a few of us that are interested in lifestyle. But, if you've been doing the same thing for 30 years, it's much harder to go back and sort of change your mind and reevaluate things when it's so ingrained in what you've been doing. So I can sort of see the reasons of why people are sticking to their guns, so to speak. And from my standpoint, I don't want to preach and force people to change, but I do want to try and open their eyes. So in my medical practice, I've actually started writing a blog for the past 2 years or so to the whole medical practice, kind of trying to focus on the primary care doctors and the specialists as well, but to show them that we need to reevaluate things. And that's the number one message. I'm not going to say, look, everybody needs to be low carb, high fat. I'm going to say, look, we need to all reach our own conclusions, but we need to understand that there's a discussion here. There's a question here, because what gets me is people be like, oh, no. There's one way to do it, the AHA guidelines, and that's it. And there's no discussion. There's no even thinking about it. So one of my main goals is just to get people to open their eyes, open their minds, and reevaluate things. Because even if it's a second tier approach, you need something when your first approach isn't working. You need another plan. And if I can get people to sort of say, okay, the low fat, low calorie type of intervention is not working, maybe I'll try this low carb, higher fat intervention and see if that works. You do that enough times and you start to see some improvement, and you'll say, maybe next time I'm not going to try it as my second line approach. Maybe I'll try it as my first line approach. And you need that sort of personal experience because, doctors like their own personal anecdotes. Anytime there's a new study that comes out that is against sort of the standard of care, people's first reaction is usually, that doesn't apply to me because I know I've got, plenty of experience doing it this way. It takes time for them to sort of catch up with their own personal anecdotes. And I think I'm the same way. I think everybody is. So the message I'm trying to get across to my medical group is open your mind. Let's be open to other options. And here happens to be a very good option, and this is why. But it's definitely like a salmon swimming upstream. It can certainly be a challenge at some points.
So you mentioned the elephant in the room is this cholesterol thing, right?
Mm-hmm.
So,
right.
I mean, that for most of us lay people and anybody that wants to try it, most of the time, if they go to their doctor and say, this is what I want to try, the doctor says, absolutely not. You're going to get cholesterol is going to clog your arteries and you're going to die of a heart attack.
Right.
And that's a very difficult thing to combat, a difficult perception to combat. And we know now that those of us that have studied this a lot, that that's not exactly true. But if I try and tell someone that, it doesn't resonate because I'm not a doctor, let alone a cardiologist.
Right.
So I think it's important to get this message from people like you. So maybe if you could please kind of elaborate on the whole concept of the contribution of cholesterol to cardiovascular risk.
Sure. There's a big history behind this, and I'll try not to get too detailed, but it all sort of started when this Russian scientist was force feeding rabbits these tremendous amounts of pure cholesterol and noticed they developed plaque in their aortas. That was back in the early 1900s. And so from that study, all of a sudden they said, it looks like cholesterol causes plaque buildup in arteries. And from there, they were able to then start to define what cholesterol is, and they could break it up into the LDL, HDL components and study them a little bit more. And from there was the Ansel Keys studies, the 7-country studies, and then the Framingham study, all which would, in an observational manner, link that those who had a higher incidence of heart disease tended to have higher total cholesterol. The link was pretty weak, though, from a scientific standpoint, but that didn't keep the community from running with it. And part of the issue was it was a perfect storm of timing because you're past World War II, so people aren't dying young from war anymore. You're in the antibiotic era, so people aren't dying young from infections anymore. So all of a sudden, heart disease is becoming the number one risk and the number one killer. And you don't have sort of like a bullet to kill it. You don't have one specific intervention to get rid of heart disease. So the country was hungry for something. And that's when the cholesterol experiments sort of started to come to a head. So people grabbed onto it, and it sort of makes sense. And that's where more studies and more studies and more studies came to try and show that it was the LDL cholesterol causing heart disease. But as we know, all these observational studies don't prove cause and effect. They can show an association, and it was a weak one at that. So without going too much into the details, sort of that's how it came to be. And then once you develop a drug that can lower it and reduce cardiovascular outcomes, then the game's all over, because then Big Pharma gets a hold of it, and guidelines get a hold of it, and then it's a avalanche that you just can't stop. Because once it becomes ingrained in dogma and it's backed by big money from Big Pharma, and they start paying the physicians to represent them, and it comes in the guidelines, then you stop questioning it right now. And when I was a medical student, it was not questionable. It was clear this is the way it is. LDL is the bad cholesterol and causes heart disease. So again, it was sort of a slow progression for me to work my way out of that dogma into learning that LDL has a purpose. And that's one thing that people like yourself and Ivor Cummins and Jeffrey Gerber and Dave Feldman, these people who with an open mind, who are smart and want to question things, can open the eyes of so many people. And fortunately, lots of physicians are catching on and opening their eyes as well, that LDL has a purpose. It's not there to kill us. But there are things in our body that can cause inflammation, oxidation. They can cause vascular damage. And that can then cause the LDL to either respond to a vascular damage or, in maybe some rare cases, to be a more atherogenic particle, which can lead to the risk of heart disease. But it's not a one problem issue. It's not just LDL. In fact, LDL is probably down on the bottom of your risk factors when you talk about metabolic health, diabetes, insulin resistance, blood pressure, smoking. LDL is way down on the bottom. I mean, you look at some trials. Like there was a recent trial in New England Journal of Medicine that looked at taking people at the highest risk of heart disease and what you could do to reduce their risk, basically by lifestyle changes. And they found those who had healthy lifestyle changes reduced their risk of a first heart attack by 50%. And these were people at the highest genetic risk. And in the supplement, they list the breakdown of all the different blood tests. And if you look, the LDL is no different across the board in most of those studies. When lifestyle modification reduces your risk of a heart attack by 50%, there's no change in the LDL. And did that make the news? Were people then talking about how lifestyle changes can benefit your risk of heart disease without changing your LDL? No, that part gets swept under the rug because it doesn't fit with the current hypothesis. But when you start to see that enough times, it sort of makes you realize that, maybe this isn't as important. And what was amazing is that, it shows sort of the setting in which the LDL probably is less important. And that's in the setting of a healthy lifestyle. When you look at all these trials that have been done to look at lowering LDL cholesterol and see how that's affects your heart disease risk, they've all been done on either the low fat, low calorie diet, or even worse, the standard American diet. Well, we know those don't work. We know those create a metabolic disease in our bodies now. So why would we expect anything else, especially when drugs like statins have these abilities to reduce inflammation, which is a big component of cardiovascular disease and heart attack risk. So putting it all together, you realize that the actual data on people who are metabolically healthy, following a real food, whole food diet, low carb diet, and the impact of LDL on your health really doesn't exist. And if you look at the trials, you can see that as HDL goes up, the impact of LDL goes down. As metabolic health improves, the impact of LDL goes down. And these are associational trials again, but it just shows that there's far more to the puzzle than just LDL, and far more things are important, more important likely than LDL's component on cardiovascular risk.
Yeah, and to me, it's almost like the LDL is like a Band-Aid, that if there's damage on your arteries, inflammation and damage in your arteries somewhere, that the LDL is going to go and pack up there to help address that damage issue. So if you don't have any damage in the first place, the LDL can run up and down through your arteries and veins and through your whole system without ever being of any risk at all.
Right. Think about if you get an infection, your body gets a rush of increased white blood cells to treat that infection, and they can collect around that infection. And in some cases, that can be problematic. They can actually start to do damage to the tissue around where the infection is. They can form an abscess. But the problem isn't the white blood cells. You don't treat the white blood cells and think everything is going to get better. The problem is that initial infection.
Right.
So if you have damage to your vascular wall, and the LDL is a response to that, and sometimes our body can have an over response, and then maybe that can start to do some damage. So the LDL could have some actual damaging properties, but they're not the initial insult. They're not the main trigger. The trigger is trying to get rid of that vascular damage in the first place. And then it's a different story. And, as Dave Feldman has been very good at pointing out, LDL has a purpose. The lipoproteins have a purpose, and they shuttle energy and they respond to infections. And so just indiscriminately lowering them in everybody is not necessarily a good idea. That's why we see studies, observational studies, but studies that show women in their 60s and 70s with a higher cholesterol level live longer than those with a lower cholesterol level. That's why studies of people with familial hypercholesterolemia show that those who don't have heart disease when they're young actually end up living longer than the general population. So there's definitely a protective component to LDL, and it's such a more complex issue than is promoted in the media and within medicine itself.
Yeah, and you actually just mentioned something here that I hadn't actually latched onto or heard before, and that was the fact that statins have an anti-inflammatory benefit as well.
Absolutely.
And that to me says that even if you have studies that where statins show they may lower cardiovascular risk to some extent, how do we know that it's not the anti-inflammatory benefits of it that are actually what's causing that improvement, and not the lowering of the LDL in the first place?
That's a great question, and that's a great question that has not been answered. If you look at the Jupiter trial, that was supposedly a trial to show the benefits of rosuvastatin, Crestor, in lowering LDL and improving heart disease risk in those people without cardiovascular disease and with relatively normal, not that elevated LDL numbers, but how they improved by lowering it. Well, the other component of that trial was you had to have an elevated CRP to get in, and the statin dramatically lowered the CRP. So there was a clear, measurable anti-inflammatory effect. So how you can then say it's the LDL lowering that's the benefit is beyond me, because that's not controlled at all. Take it one step further, though. Now people testing this LDL hypothesis are looking towards the PCSK9 inhibitors, Repatha, which was studied in the 4-year trial. And that's sort of the latest and greatest. It's an attack on without getting too detailed, it prevents the LDL receptor from being degraded. So you have more LDL receptors on your liver, takes more cholesterol out of your bloodstream and puts it into your liver. So you can get LDL levels down to like 30, which is lower than we've seen in any really mainstream large-scale trial. And this was supposed to be the end of heart disease, right? If you can get LDL that low, how could you possibly have heart disease if LDL is the issue? So in the 4-year trial, there was a 1% reduction over 2 years in the risk of heart attacks. So depends how you look at it, right? Some people are saying, okay, these are high-risk people, and they were already on statins, so reducing their risk by 1% is great. But on the other hand, if LDL is really the problem and you reduce it down to almost nothing, why don't you see a much greater impact? And that's where the conversation has ended. But if you look at the data, there's one thing that no one's talking about. Again, the CRP went down.
Right.
PCSK9 inhibitors aren't supposed to have anti-inflammatory effects. They're supposed to be pure LDL lowering. But in the supplemental results section, you see the CRP go down. So again, there's this question of inflammation. And again, the LDL hypothesis doesn't necessarily hold up that it's proven that it's the LDL effect. So it's a confusing situation for a lot of people because they're getting it from different avenues. And most of the doctors that they go see are going to say, absolutely, it's the LDL. We got to get your LDL down. Anything that raises your LDL is going to kill you, because that's sort of the party line that's been taught. That's
what they were taught at school, right? And
right.
They've been telling their patients ever since they left and started in practice.
Absolutely. But when you go back and you re-examine it, it becomes clear that that's not the case. And you don't have to. I mean, look, I'm pretty much on board saying that LDL is not the issue if you have other things in check, if your metabolic health is good, if you're eating well, if you're exercising, if you're managing your stress, if your inflammation is low. I'm a big fan of now saying LDL is not that important. You don't even have to go that far, though, but I think everybody has to at least address the question and realize that the evidence supporting LDL is open to question. So don't close your eyes, don't have your blinders on, but you have to keep an open mind and understand that it's open to question.
Yeah, that's awesome. So Dr. Brian Lenskes, I chatted with him a couple of weeks ago. I know you guys were colleagues a few years ago. Did you study together or?
Yeah, Brian. Brian's great. He's such a great story. So we were residents together at Scripps Mercy here in town in San Diego. And I think he was 1 year behind me. So I was chief resident when he was a third-year resident, and then he came in as the next year's chief resident. And then he stayed in practice in the Mercy area in San Diego. And he's such a great story because he shows really what has to happen for most doctors to have an awakening, because he's a very smart guy. He's a very good doctor. His patients love him, and he wants to do his best and take care of the patients. And I think he was getting a little frustrated with difficulty improving his patients' lives, but it wasn't until he had that personal experience. He was a little overweight. He likes to joke about how people like me never had to worry about weight, and he always had to worry about weight. It's not always that clear cut, but he was a little overweight and having his own struggles. And then he found low carb, and boom, did he have fantastic effects. I mean, he started feeling better. He improved his health. He improved his weight. And he said, if this works for me, this is going to work for my patients. And it's that aha moment that people need to kind of trip them over. And now he's seen amazing results. I mean, the information he's telling me about the number of people he's getting off of insulin, about the weight loss he's seen, about the metabolic health improvements he's seen in his patients is phenomenal. And that's what we need. We need people like him to spread the message so that a doctor doesn't have to wait for their own personal experience or their own aha moment, but can learn from someone like him. He has so much to teach the rest of the medical community because of his enthusiasm and his success and his just intelligence, the way he approaches this.
Yeah, and that's what excites me so much about him and this. When we started this organization, our whole idea was to try and help get this message out to people beyond the bubble of believers that were already going around to these low carb conferences, and we wanted to get out beyond that. And to have him approach me about this was super exciting because he is so enthusiastic about it now. That not only his personal improvement, but now in the last few months, he's taken or helped 11 of his patients to get off insulin completely. And he can't believe it. And now, for me, the most exciting part is now he wants to go and tell the other doctors about it.
Yeah.
And as I was mentioning a bit earlier, I'm a bright guy. I can read all the medical journals and I can read all of that stuff and learn about it and be a guru. But when I try and talk to a doctor about it, he's going to blow me off. But that's just how it is.
That's just
whereas if Brian stands up there and tells them about it, now there's a chance that they're going to listen.
Exactly. And especially when he says, how many people have I gotten off insulin in the past 15 years of my practice?
Right.
Big goose egg, 0. How many people have I gotten off in the past 6 months or whatever, whatever time frame, 10, 20, 30, whatever the case is. I mean, it's you can't argue with that right. Data, with that experience.
And so now he's starting to put on these not conferences, but seminars, I suppose, where he's inviting, I think it's open to anybody, but he's inviting mainly medical professionals to come to try and help educate them about this. And he's invited you and included you in that whole program. And his big thing is saying, he feels the same way. Like when I try and tell people this, even the doctors, the first thing they say is, are you going to die of a heart attack? And so he feels it's really cool to be able to bring you in to address that part of it. So he can say, look at all the therapeutic benefits I'm seeing for other things, diabetes, obesity, all these other issues that he's now able to address with his patients. And if they're worried about advocating this because of the cardiovascular disease risk, then here's someone that can address that concern for you.
Absolutely.
So, yeah, I think the first one is on the 14th. I forget the name of his website where you can find out the information about it, but I will post it.
I think it's just Low Carb Doctor.
Is it low carb MD or something like that? I forget, but I'll put it in the comments when I post this, so people can go and learn about it, because we want to get as many people as we can to to that event, and he intends to have this as an ongoing thing.
Yeah. So funny story. So it's lowcarbmd.com. I just looked it up.
Okay.
But I just got a message yesterday, as timing goes. I just got a message yesterday of someone who saw her primary, wanted to talk about a ketogenic diet. Primary said, nope, you can't do it because your cholesterol is going to go up and you're going to die of a heart attack. She signed up to go to the conference, and she called me for an online consult that I do to get a second opinion about this. And we need more of this. I mean, this is the way the world has to go. So I want to find out who her doctor is and get her doctor to go to Dr. Lenski's conference. I mean, that's
absolutely.
And then
we were at was it a Christmas thing the other day, and someone talked about how their doctor was advocating not keto, but like eliminating carbohydrates from their diet to address the issues they were having. And my first thing was like, who's your doctor? I need to find them so they can get them to our conference, because those ones that are least open-minded to it are the first ones that we need to get to, and and we'll grow from there.
Right, and you mentioned Brian Lenski's conference, his seminars, and then of course there's also your conference, the Low Carb USA conference, that'll be in San Diego in July, right?
This July, correct.
And I mean, you've got the who's who of the speakers. It's going to be a fantastic conference, and I'd encourage doctors to go to that as well, because then they can really see the power of the community and the power of the message. And it's that type of conference that we need more of to educate people, at least to open their eyes to what's out there.
Right. I mean, we've slowly grown. We did our first one in San Diego in 2016, and we just had our second one now in August, and we did one in January in Florida. Mm-hmm. We've got another one in 2 weeks' time in Florida. We hopefully in November going to have one now in San Francisco, and possibly in 2019 have one in New York.
Wow.
As well. So as we get better at this and we're able to get our minds around the overhead of putting another one on, we're slowly growing. And actually was Nina Teicholz. We met with her in New York a little while back, and she was saying, like, now that we've got all of these videos from all of these conferences, that we should try and get a series of those videos approved for CME credits. She said, because you guys need to get into every single city in the States and Canada, wherever in the whole world. You need to get into every city, but you can't do that. Doesn't matter how big your organization grew, you still couldn't get into every city. Right. And yes, we have CME credits available for people that do attend the conferences that we do, but there's a lot of people that don't hear about it, that can't travel, that there's all sorts of reasons they can't make it, and so eventually getting a video program approved, I think will go a long way as well to starting to get, because now doctors who just kind of heard about it and thought, oh, well, this is going to be much easier to sit in my lounge and listen to 25 hours of lectures and get all my credits that I need instead of paying for and traveling to an event somewhere.
Yeah, that's the way the world of CME is going. I mean,
maybe more will listen. I think Brian said, I mean, he had tried it out for himself before he got to the conference, but it was only when he was there and he listened to all these world-renowned researchers and doctors and whatever, talking about it and validating what he'd been trying on himself. It was only at that point that he really felt confident to now go and bring this to his patients.
Right.
And now he's super excited because he's had such enormous success within his practice.
Right.
So I'm excited about that. I'm hoping that I said to him when I interviewed him that I hope that this becomes a model that we can find a way somehow to start encouraging other people and other docs or whatever in other cities to start doing the same thing. And that's the way we can get this word out and teach people.
Yeah, and that's so important. So important. Just it has to be part of the conversation. Again, it doesn't mean everybody's going to use it as a first line therapy, but it has to be part of the conversation, because you've got the vegan and vegetarian movement is a very strong movement. And it's not to say you can't be healthy and vegan and vegetarian. I mean, you can. It's a challenge for a lot of people, but especially if it's sort of a high fat vegetarian type diet, that can be a healthy way of diet, but it's certainly not the only way. And once you see that medical schools are starting to promote nutrition, that's exciting. But then you realize they're 100% vegetarian and closed to other options. That's a huge problem. That this conferences like yours and Dr. Lenskis and podcasts like this and information that goes out, has to be the primary focus to make it part of the conversation. Because anytime you start to present the evidence that's saying this is the way it is for everybody, I mean, that just doesn't work, especially when you're talking about something that's been tried for decades with the low fat, reduced calorie nutrition that's been tried and tried and tried and failed and failed and failed for the most part. So we have to just further the conversation.
The last thing I want to make sure that you get out there is that you do a very cool podcast as well, and you get some of these top-notch speakers and people in the low carb and ketogenic space onto your program. So if you could maybe just put it out there, tell people how they can get to see that podcast, that'll be a good way to end this, I think.
Yeah, well, thank you for mentioning that. The podcast has been a lot of fun. I really enjoyed connecting with all these people and having conversations like this to get the information out there. And, you know, I get to pick who I'm speaking with. So of course I pick a lot of the low carb community type people, but it's a general health podcast as well. So I talk about meditation and mindfulness and sleep and exercise and try and get all the main pillars of health. But a big component obviously is nutrition. So it's called the Boundless Health Podcast. So you can find it on iTunes or Stitcher or on my website at drbrettschur.com. There you can find my blog, my podcast. You can find more about my book, Your Best Health Ever. So the website's a good place to start, or looking for the Boundless Health Podcast on iTunes and Stitcher. So yeah, thank you for mentioning that. Yeah,
no, absolutely. And I'm really looking forward to our first meeting with Dr. Lenskis and you. I think it's next weekend, right? The 14th?
It's Sunday the 14th, yes.
Sunday the 14th, yeah. So look it up on that website. I'll put it in the notes as well. And let's start to get even if you're just on the fence, like get out there and come and listen to it and see if it's something for you. I feel like my personal opinion is that we're often very guarded in saying it's not for everybody, and it's not. But I actually do feel that in the end, it's going to turn out to be where it is actually the best option for most people.
Agreed.
And it almost makes me think about, I did an overland trip in a Land Rover through sort of the whole of Southern Africa. And when we got into Malawi, the incidence of malaria there is it's mind-boggling. And we actually ended up taking someone that was very sick in a little village to a nearby hospital, and was talking to the doctor there, and he basically said, if anybody comes in and they're sick at all, the first thing they do is treat them for malaria, and then say, okay, well, when you come back, if you haven't responded to that, then we'll start looking at what else might be wrong with you.
Right.
It's almost 99% of the time you've got malaria. And I feel a little bit like this is a little bit like that, where you mentioned that it may eventually become the first line of treatment and not the last one.
Right. We should automatically treat people as if they have insulin resistance. And if you look around at the general population, you're going to be right about 70% of the time.
Right. And the thing about it is that you respond so quickly if it is going to help, that
right.
It's not like you have to go for a couple of years and see, okay, has it made any difference?
Right.
It's like literally a couple of weeks. And you can see if the person's responding, then, hey, this is worth following. And if not, then maybe you need to look at another option.
And that's the other point that needs to be really, really impressed to all the physicians. Is like, look, this doesn't have to be a lifetime experiment, but it's worth the experiment. Have them try it for a month, 2 months, 3 months. And if they lose weight and they feel better and they have more energy and their HDL goes up, their triglycerides go down, their sugar goes down, their A1C goes down, their insulin goes down, how can you argue with that, right? So you just got to give it a trial and you're going to see the results. You don't need them to be on it for 10 years to know if you're going to have some effect. You're going to see that immediate effect. And that's pretty impressive once you see it. Yeah, it's a good point.
Yeah. So anyway, I think that's a good way to end this.
Yeah.
Thanks again for your time. I look forward to seeing you next Sunday.
Yeah.
Yeah, let's see where we can take this thing.
Great. Thank you.
All right.